Welcome to Bone Break, the 10-minute podcast that covers basic orthopedic content for the aspiring orthopod. Get a coffee, go for a walk, or just sit back and relax. It's just bones for 10 minutes. Today's topic is distal radius fractures. A 76-year-old man presents to the emergency room with a swollen, deformed left wrist. He was cleaning the house when he tripped and fell. After the fall, he had immediate pain and came to the emergency department. He takes no medications and has no prior surgical history. He has no known drug allergies. He is right-hand dominant and works as an accountant. He is a smoker and drinks socially. He has no numbness or tingling associated with the injury. He is neurovascularly intact. The emergency doctor has ordered a PA and lateral view of his left wrist. Upon reviewing the images, you identify a displaced and shortened, dorsally angulated fracture of the distal radius. This is commonly referred to as a Colles fracture. After the patient undergoes a closed reduction of the distal radius, repeat images are taken. Despite the reduction attempt, the 11-22-11 rule is broken, suggesting that there is still a misalignment of the fracture. You consent and book the patient for an open reduction and internal fixation. The patient comes to the OR. The correct side is marked. You do the modified Henry's approach to the distal radius and use a volar distal radius locking plate. Following the operation, he is put in a volar back slab and told to be non-weight bearing for 2 weeks before following up in the fracture clinic. In this episode, we have highlighted a case example of the operative management of a distal radius fracture. Distal radius fractures are common. They are even more common as individuals age. Older patients typically break their wrist from low-energy falls, while younger patients are involved in high-energy incidents. The most common mechanism is a fall on an outstretched hand, commonly known as the foosh. In our case, we highlight key points about the distal radius fracture. An elderly man presents to the hospital with a swollen, deformed left wrist. What further information would you want to know about this patient? When gathering history from a patient with a distal radius fracture, or any patient in general, the AMPLE framework can be helpful for getting the key information necessary for clinical decision-making. In this mnemonic, A represents allergies. It's important to know about any allergies the patient may have, as this can affect medication choices, for example antibiotics, and surgical materials, for example the need for latex-free gloves. M stands for medications. Understanding the patient's current medications is important, especially if any need to be held before the OR. P is for past medical history, not just because we're looking for a reason to consult medicine, but some conditions, such as diabetes, may affect healing. Past medical history should also include a thorough social history encompassing hand dominance, occupation, and smoking status. Returning to our mnemonic, L signifies the last meal. This detail is important as it may affect the timing of when the patient can be taken to the OR. Finally, E stands for events prior to the injury. Specifically, we'll want to understand the mechanism of injury, particularly in elderly patients. It's important to ascertain whether the fall was purely mechanical or preceded by symptoms like esprit syncope or cardiac issues, which may require a larger workup. This is especially important in hip fracture patients, which we will discuss in a later episode. The patient works as an accountant, smokes a pack a day, and drinks about 2 beers each night. He is right-handed. What impact does smoking have on surgical healing? Smoking can delay surgical healing and bone healing. It is important to discuss smoking cessation in patients undergoing orthopedic surgery. It may be useful to use motivational interviewing to determine if the patient is interested in cessation. Regardless, nicotine patches and gum can be useful for inpatients to decrease smoking during the perioperative period. What physical exam findings are important? On physical exam, we can start by doing a general inspection of the wrist. You will want to note any open wounds, deformities, swelling, general skin quality, and any obvious hematoma formation. You can also palpate the wrist to ensure that the compartments are soft and to localize where most of the pain is coming from. In some cases, it might be worth assessing range of motion as well, but in cases of obvious fractures, this is often extremely painful and not required. It is especially important to document a neurovascular exam, including motor function, sensory function, and pulses. Take a second to think about how we can test motor function. What nerves allow our hands and wrists to move? There are 3 nerves to test in the upper extremity: the radial, ulnar, and median nerve. To test the radial nerve, ask the patient to do a thumbs up. To test the ulnar nerve, ask the patient to abduct their fingers. To test the motor function of the median nerve, ask the patient to make an OK sign. To get a true sense of function, these actions should be performed against resistance. Try these movements for yourself. Thumbs up for radial, abduct your fingers for ulnar, and OK for median. When assessing sensation, the radial nerve can be tested on the dorsal aspect of the first web space. The median can be tested on the radial border of the index finger, and the ulnar nerve can be tested by feeling the ulnar border of the pinky. Again, take a second to map out where you would test these areas on a patient. Acute carpal tunnel syndrome can develop because of the fracture, resulting in symptoms such as numbness and tingling to the distribution of the median nerve, that is, to the radial 3 and half of the fourth digits. Finally, it's important to remember that if a closed reduction is performed, conducting and documenting a full neurovascular exam before and after the procedure is essential. Following a complete physical exam, X-rays are ordered. What imaging would you like to get? PA and lateral X-rays of the wrist are typically ordered for a distal radius fracture. It is often advisable to also image the joints above and below to rule out additional injuries. This means considering X-rays of the elbow and potentially the shoulder as well. For the joint below, the carpal bones. These are usually well visualized in wrist X-rays, so distinct views of these bones are generally not necessary. In cases of particularly complex fractures or when there is uncertainty about intra-articular involvement, ordering a CT scan of the wrist may be considered to help with surgical planning. What are the eponyms of common distal radius fractures? An eponym refers to a common name for a medical phenomenon. This is not the same as a classification. The eponyms of distal radius fractures are attributed to the doctors who originally described them. Two common fractures are known as the Colles fracture and the Smith fracture. The Colles fracture is an extra-articular fracture with dorsal angulation. On the other hand, the Smith fracture is an extra-articular fracture with volar angulation. The Colles is the most common fracture from a Fouche. Radiographically, the Colles fracture is shortened, dorsally angulated, and translated. The images show a displaced Colles fracture. After the patient undergoes a closed reduction of the distal radius, repeat images are taken. Despite the reduction attempt, the 11-22-11 rule is broken. What is the 11-22-11 rule? The 11-22-11 rule is a set of criteria used to assess for proper alignment of the distal radius fracture, and it refers to 3 specific measurements on X-ray. First is volar tilt, which is described as the angle formed by a line drawn perpendicular to the radial shaft, and a line that passes through the tips of the volar and dorsal rims of the articular surface. We can assess this angle on the lateral X-ray of the wrist. Normally, the volar tilt of the distal radius is about 11 degrees. Radial inclination describes the angle of a line drawn between the radial styloid and the ulnar border of the distal radius with respect to a line perpendicular to the radial shaft. The normal value of this radial inclination can fall between 21 to 25 degrees, but we often reference 22 degrees since it's double 11 and therefore easy to remember. Radial height, also known as radial length, is measured as the distance between 2 lines drawn perpendicular to the long axis of the radius in the PA projection. These lines are drawn from the apex of the radial styloid and the level of the ulnar aspect of the articular surface. Normal radial height is usually around 11 millimeters. It's important to remember that there is anatomic variation among individuals, and that these normal values should be interpreted with this in mind. However, if these measurements fall outside the normal limits, it indicates that the fracture is misaligned. In such cases, correction is required either through closed reduction and casting or open reduction and internal fixation, i.e., ORIF. What are the indications for surgery? There are a multitude of indications for surgery, including loss of radial inclination, height, and volar tilt. Other indications include intra-articular volar shear fractures, fractures with associated intercarpal ligament injury, other intra-articular fractures, and open fractures. Furthermore, the patient's function and age are often considered when deciding whether or not a surgery is needed if there are softer indications for surgical treatment. In older patients, sometimes displacement and non-anatomic alignment may be well tolerated. You consent and book the patient for an open reduction and internal fixation. The patient comes to the OR, the correct site is marked, you do the modified Henry's approach to the distal radius and use a volar distal radius locking plate. What approaches can be used for this operation? An open reduction and internal fixation describes 2 parts of the typical bread and butter surgery for orthopedic trauma. First, you must be able to see the bone to reduce the fracture. This involves making an incision through the layers of skin to see the bone. Open reduction refers to putting the bone back in the correct alignment, while internal fixation refers to the use of plates, screws, nails, and other orthopedic implants to hold the reduction. You can learn more about these in our first episode on orthopedic implants. The modified Henry's approach is commonly used to fix the distal radius fracture. The modified Henry's approach is through the sheath of the flexor carpi radialis. The classic approach is between the brachioradialis and the radial artery, while the modified approach is ulnar to the radial artery. Once the FCR is incised, the pollicis longus muscle is swept to expose the pronator quadratus. The pronator quadratus is a square muscle that is then released off the bone to expose the distal radius. We often use a locking plate designed for the distal radius to fix these fractures. Locking refers to the type of screw holes in the plate. Locking screws are screws which have threads in the head of the screw, allowing fixation between the screw and the plate. This means the screws have less chance of backing out a poorer bone, as the fixation no longer requires friction between the bone and the plate. If you want to learn more about this, there are resources in the show notes. Following the operation, he is put in a volar back slab and told to be non-weight bearing for 2 weeks before follow-up in the clinic. Core questions. The following questions are some key concepts about this topic that you should review prior to your rotation. Know the common mechanism causing distal radius fractures and who are likely to get them. Describe an upper extremity physical exam. Know the 11-22-11 rule and indications for surgery. Describe the difference between Colles and Smith fractures. The attending questions. The following questions are more advanced for those really looking to impress on their rotations. What is the difference between the modified and classic Henry's approach? What nerve is most at risk during the volar approach to the wrist? What is a locking plate? This podcast is designed for you to re-listen and test yourself at each core question, as indicated by the bell. Thank you for listening to Bone Break. I'm your host, Dr. Cade Van Kampen. We will see you next time for the most common lower extremity injury, ankle fractures.